Hi everyone, Dr. Minasre here. In this third part, we transition from image acquisition to interpretation. The goal is not to become an expert in quantitative echocardiography, but to master rapid visual assessment, eyeballing, to identify critical pathologies at the bedside. Our fundamental evaluation is left ventricle function, right ventricle function, pericardial effusion, and IVC assessment. Then we move to pattern recognition for immediate clinical correlation. Starting by LV assessment, function assessment, we have two visual estimation and one quantitative measurement. First, we'll talk about endocardial excursion. This is a visual estimation of how much does the LV wall move inward during systole. Visual estimate an area function shortening of approximately 30 to 40% for normal function. Then we have myocardial thickening. The muscle itself should thicken by approximately 40% during contraction. Little or no thickening indicates dysfunction. Then we have EPSS, E-point septal separation. A simple objective measurement in the parasternal long axis view using M mode. A distance between the mitral valve leaflet and the septum more than 7 to 10 millimeter is abnormal and correlates with low ejection fraction. If you use these key patterns with clinical correlation, here, for example, we have hyperkinetic LV, cavity nearly obliterated in systole, vigorous movement. We'll consider septic shock, vasodilation, or hypovolemia. But if we have severely depressive LV function, minimal warm-up motion, little thickening, and increased EPSS, we'll consider cardiogenic shock, myocardial stenting. If we have a segmental wall abnormalities, this is an area that is akinetic or dyskinetic or paradoxical motion. In the parasternal view, we should consider acute coronary syndrome. Now let's turn our attention to the right ventricle. Assessing the RV is key to suspecting PE. We do this through an integrated visual approach. We start with the RV size and shape. In the apical four-chamber view, compare it to the LV. Normally, the RV is smaller, less than 2/3 the size of the left ventricle. If they appear equal or the RV is larger, it's dilated. In the short axis view, a crescent-shaped RV is normal. A circular one is not. Then observe the septal kinetics. If you see the septum flatten and the bow in the left ventricle, that we call a D sign, it signals significant pressure or volume overload on the right side. We have a more quantitative measure is TAPSI using M mode on the tricuspid annulus and an excursion of less than 17 millimeters indicates RV systolic dysfunction. When these signs come together, dilated, dysfunctional RV, flattened septum, it creates a pattern highly suggestive of massive PE or acute pulmonary hypertension. One specific pattern we call McConnell sign. Akinesia of the mid-right ventricle walls with spared contracting apex is highly specific for acute pulmonary embolism. Identifying pericardial effusion is straightforward. It appears a black, anechoic space surrounding the heart. A key tip here is to use the descending aorta as a landmark. Pericardial fluid sits in front of it, while pleural fluid sits behind. But the real emergency is tamponade. The echo sign is direct, a pericardial effusion plus diastolic collapse of the right ventricle or atria. This happens because the RV is a low-pressure chamber that gets compressed. A supporting sign is plethoric non-collapsible IVC. The high pressure in the pericardium prevents venous return, leading to a dilated IVC that doesn't collapse with aspiration. This is a very sensitive, though less specific sign. Then our final point is using the IVC to assess volume status. In the subcostal view, simply measure the IVC diameter and its collapsibility with inspiration. We look for a diameter change greater than 50%. A collapsed IVC under 1.5 centimeter with strong collapsibility suggests low central venous pressure. This correlates with low volume status or vasodilation, and the patient is very likely to be fluid responsive. On the other hand, a plethoric IVC over 2.5 centimeter with poor collapsibility suggests a high central venous pressure. This correlated with right heart failure, tamponade, or fluid overload. So in summary, level 1 POCUS gives you an immediate visual decision. Ask yourself these 5 questions. Is the LV hyperkinetic? Is the LV severely depressed? RV is dilated or dysfunctional? Is there pericardial effusion or tamponade? IVC is collapsed or plethoric? The true key is integration. Cross this reference, the sonographic pattern with your patient's clinical story. For example, hyperkinetic LV, collapsed IVC in a septic patient. We need to initiate fluid resuscitation. The same hyperkinetic LV with plethoric IVC should alert you to underlying heart failure. And when you are faced with that undifferentiated shocked patient, remember the RASH protocol. This powerful tool helps you rapidly assess the pump, the tank, and the pipes to identify the cause of shock within minutes. Finally, always remember that proficiency in POCUS relies on a foundation of competency. It's built through structured training, supervised practice, rigorous validation, and the regular maintenance of your skills. Thank you all for your attention.